A 43-year-old gentleman referred by the GP because he had vague right side loin pain and ultrasound showed complex cyst in the right kidney. How are you going to evaluate him?
So I will see this gentleman on urgent basis in my clinic. I will take a history regarding the pain on the right side, the onset, the duration, any associated symptoms like hematuria, any lower renal tract symptoms. I will ask also about any systemic symptoms like weight loss, cachexia, nausea and vomiting. I will ask also in this patient whether he is known to have any stones before, whether he know about this cyst before or not. Also, I will ask about any risk factor for renal cancer, like smoking, obesity, hypertension. In this patient, I will ask about his past medical history and medication, past surgical history, any surgery or radiotherapy before. I will ask about family history of any known cancer, especially renal cancer. And I will ask about his habits. After that, I will move to examination. In the presence of chaperone with the patient consent, I'll examine his BMI, blood pressure, and then I'm looking for any features of cachexia, any palpable lymph nodes, and then I will examine the abdomen, looking for any palpable mass or tenderness in the loin. I will complete examination of the genitalia as well. I will examine the lower limb for any edema, and then I'll arrange for some investigation. I will arrange for urine dipstick, looking for any non-visible hematuria and proteinuria. I will arrange for blood tests, including full blood count, kidney function, and I will arrange for imaging of the cyst. Since the patient already had an ultrasound, I will arrange for a triple phase CT for a better characterization of the cyst.
Okay, that's good. He's quite healthy, he's quite young. This scan finding really held him with a lot of surprise that something is happening in the kidney. You said about family history. What is the role of family history in renal lesion?
So about 5 to 8% of renal cancer are hereditary, and those patients usually tend to have an earlier presentation of renal cancer, usually with bilateral or multiple lesion. So this is my concern.
Do you know any familial renal lesions?
Yes, I know about the von Hippel-Lindau disease, hereditary papillary renal cell carcinoma, hereditary leiomyomatosis, and papillary renal cancer, Birt-Hug-Dobby syndrome, and tuberosclerosis. So all of them associated with the hereditary type of renal cancer.
What is von Hippel-Lindau disease?
So von Hippel-Lindau disease is an autosomal dominant disease, which usually occur due to loss of the von Hippel-Lindau tumor suppressor gene on the short arm of chromosome 3. And this will lead to lack of control over the hypoxia-inducible factor 1, which will accumulate and then start generating a lot of mediator like vascular endothelial growth factor, platelet-derived growth factor, and all this contribute to the development of renal cell carcinoma. It's happening in 1 in 36,000. Male to female ratio is equal, and usually the symptoms start at the age of 20 years.
Okay. What is tuberosclerosis? What is the association with the renal lesions?
So tuberosclerosis is characterized by the formation of angiomas in the brain, in the skin, and in the kidney. So usually the patient will be presented with mental retardation, epilepsy, adenoma sebaceum lesion in the face, and multiple lesions in the kidney, including either cyst, angiomyolipoma, oncocytoma, or sometime in 5% of the cases, renal cell carcinoma, mainly chromophobe.
Okay. You said to evaluate the right kidney lesion, you will arrange a 3-phase kidney CT scan. Can you explain this further?
So this composed of a native phase first, which is important to assess for any calcification and to assess for the baseline an attenuation value in the kidney and look for any metastasis in the liver. And then after that, we give the patient the IV contrast, and we take another images at 80 to 100 seconds, aiming for the parenchymal phase. And then I will take delayed images at 8 to 10 minutes, looking for the excretion phase. And the main thing is that I'm looking for any abnormality in the kidney and looking for enhancement more than 15 Hounsfield unit, which is regarded as a significant for renal mass.
Okay. Let us assume that this patient had a CT scan which showed left side normal kidney, normal excretion. Right side, it is a complex cyst with signs of enhancement in the cyst wall, and there is a septation which is also enhancing. How will you further characterize these cysts?
So further characterization is according to the Bosniak classification, which is a classification of complex renal cysts depend on the CT finding. So for this patient, if there is an irregularity and enhancement in the wall and irregularity enhancement in the septa as well, this is mostly a Bosniak 3 cyst, which carry a risk of malignancy in about 25% of the cases.
Could you explain the other Bosniak types?
So Bosniak 1, it's usually thin-walled cyst without septa or enhancement or calcification. Bosniak 2, it may contain a few hairline thin septa or thin calcification, and usually mild thickening of the cyst wall, no enhancement, no internal echoes, and usually the size is less than 3 centimeter. Bosniak 2F, or the hyperdense cyst, which characterized by more dense calcification in the septa, some irregularity on the wall, and also it may show mild enhancement in the septa, but there is no internal echoes, and usually the size is more than 3 centimeter. It carry about 12% risk of cancer. And then Bosniak 3, which characterized by more thickened irregular cyst wall, thickening and irregularity with calcification, dense calcification in the septa, and there is a significant enhancement, but there is no internal echoes. This is Bosniak 3. And Bosniak 4, when there is an internal echo or soft tissue element inside the cyst, which carry a high risk of malignancy, around 75%.
Okay, so in your own words, now this patient unfortunately labeled as Bosniak 3, and how are you going to manage him?
So I will counsel this patient after I get the result of the CT. I'll discuss it in the MDT, and if there is and I will arrange for a CT chest as well for a proper staging of the patient, and then I will see the patient in the result clinic in the presence of the oncology nurse specialist. I explain that this cyst can have a 25% risk of being malignant. Therefore, most likely the recommendation from the MDT is to offer the patient surgery to remove the cyst. However, if the patient is not keen to consider surgery, then I will keep him on close follow-up.
So this patient, because of the young age, is not quite happy to go ahead with surgery. The lesion is 2.3 centimeters. So how are you going to follow him up?
So this patient, if he's not keen to have the surgery, then we can follow him according to the active surveillance protocol, which is a protocol applied to renal masses less than 4 centimeter in diameter. And usually we defer the active treatment since the lesion is a small, patient is asymptomatic. So our aim is to avoid any treatment-related toxicity or side effect. So there is a protocol for that. And then the trigger for active treatment will be a change in the size or appearance of the lesion. For this patient to be fit for the active surveillance protocol, I will advise him to have a renal biopsy before inclusion in the protocol. However, I am aware that the outcome of renal biopsy in cystic lesion may be suboptimal, unlike the solid lesion.
Okay, time's up now. Good presentation. I have no concerns at all. This is one of possible scenario. Just preparing a patient with a suspicious lesion in the ultrasound. So they may deviate towards what is CT scan, what is the CT renal protocol, and those things. They may deviate about the various hereditary form of renal malignancies and this Bosniak calcification, and then it just stops short of actual management, and you've done perfectly well. If you have no questions, I'm happy to start the next scenario.
Yes, please.
Okay, your time starts now. You are referred a 63-year-old lady. She is known diabetic and hypertension, well controlled with medications. Past history of myocardial infarction. 3 years back had 2 stents placed. The reason for the referral is visible blood in the urine. She had flexible cystoscopy which was normal. CT urogram done showed possible lesion in the left kidney measuring 10 centimeters. There is no signs of any lymph node metastasis or vascular involvement. How are you going to treat her further? Her examination findings are not significant.
Sorry, this is on ultrasound or CT finding the 10 centimeter mass.
CT urogram done for evaluation of visible hematuria.
Okay. So for this patient, I will see her urgently in the presence of the oncology nurse specialist. I will review, before that, I will review her images and make sure that she had the correct protocol for renal characterization. So I will review the images, and I may need to arrange for a proper triple phase renal CT for a better characterization of the lesion. And I will arrange for a CT chest as well for a complete staging. I review the images in the MDT, and then I will review the patient in the clinic with the nurse, with the oncology nurse specialist. After that, I explain to her the finding of a 10 centimeter mass, which is high likely to be cancerous. And if the tumor according to the CT is localized and there is no lymph node and other metastasis, then I will discuss with the patient the option of treatment in the form of radical nephrectomy. However, she has multiple comorbidities, diabetes, hypertension, and the cardiac stent. If she is proven to be high risk for the surgery, then maybe we will just treat her palliatively with symptomatic treatment.
Okay. How will you decide whether the patient needs a separate renal protocol CT scan, or we are happy with CT urogram? How will you decide that?
It's usually the radiologist will review the images in the MDT. If he is happy that he have a baseline attenuation from the renal tissue, and then after the contrast injection, he's happy with that there is a significant enhancement, and we can comment on the renal pedicle lymph node and local extension, then maybe we can go ahead with the CT urogram. But most of the time, we need a proper triple phase CT for better characterization.
Okay, so this patient CT scan clearly proves presence of possible renal cell carcinoma. And how will you evaluate her fitness?
So I will refer the patient to my anesthetic colleague for assessment of fitness. I am aware of a protocol called the CPIT, which is cardiopulmonary exercise test, which is used for assessment of a patient for major surgery. So I can refer the patient for CPIT for proper assessment for the patient, optimization during the surgery, and planning for her post-operative course, whether in ITU or in the ward, and give her a precise risk about the anesthesia and the surgery.
Can you explain the CPET test?
So the CPET test, basically, it is done in a special department where there is a resuscitation equipment available, because there is a very, very low risk of morbidity and mortality because of the exhaustion associated with the test. The test composed of monitoring of the patient for pulse, blood pressure, respiratory rate, oxygen saturation, a 12-lead ECG, and measurement of the inspired and expired gas for VO2 and VCO2. And then the idea is that we put the patient under stress by either treadmill or by a bike. Usually it is 4 phases. Start with a rest phase, then unload exercise, and then ramping, and then recovery phase. And during that, we observe the vital signs of the patient, and we measure the anaerobic threshold for this patient. And if the anaerobic threshold is less than 8, this indicates that this patient is high risk for surgery and anesthesia.
Okay, so let us assume that this patient's CPET test shows that she is fit for anesthesia and diabetic hypertension controls are well adequate. How are you going to take it forward? Her renal lesion is 10 centimeters. How will you decide between partial and radical nephrectomy?
So according to the EAU guideline, we should offer a partial nephrectomy for a patient with a T1 tumor, which means that tumor less than 7 centimeters. So this patient, the tumor is more than 7 centimeters, so she shouldn't be a candidate for partial nephrectomy unless the patient is having poor kidney function in the other kidney, or maybe the systemic disease like diabetes and hypertension have a potential for further renal damage. But still in this patient, more than 7 centimeters, I would consider radical nephrectomy rather than partial nephrectomy unless it is a solitary kidney or synchronous renal tumor, bilateral synchronous renal tumor.
Okay, she has no risk factors and there is no need for any compulsive need for partial nephrectomy. How are you going to prepare her for radical nephrectomy?
So I'll consent the patient first according to the BAUS. I will use the BAUS leaflet. I'll explain about the benefit, risk, and alternative for the surgery. I will explain that this surgery nowadays is done by laparoscopic or robotic. It's associated with the usual risk of anesthesia, infection, pain, need for blood transfusion. Specific complication may include bowel injury, paralytic ileus, abdominal wall sepsis, hernia following the surgery, and in the long term, there is a possibility of deterioration of her kidney function. So I will consent her for that, and then we'll proceed with the surgery, which is done nowadays minimally invasive with a robot.
Okay. Could you explain the robot arms used for radical nephrectomy?
So the robot will be using a port for the camera, and then 2 to 3 arms controlled by the surgeon who is using the console, and the assistant will be near the patient and the nurses to insert these ports.
What is the advantage of robot compared to laparoscopic assisted radical nephrectomy or open?
There is no oncological outcome benefit. Both of them, they have the same oncological outcome. However, the robot associated with less operative blood loss, less pain post-operatively, and shorten the hospital stay. So these are the main advantage.
Okay. What is your take on lymph node dissection?
So lymph node dissection is not recommended unless they are clinically enlarged, because only 20% of lymph nodes are proven to be involved by cancer. So there is no recommendation for a routine lymphadenectomy. The only indication if the nodes are enlarged, and there is no consensus about the extent of lymphadenectomy in case of renal cancer.
Okay, so what are the indications for lymph nodes, if at all, dissection?
Only if the nodes are clinically enlarged, either perioperatively or in the imaging before the surgery.
What is your take on removal of the adrenal gland?
So removal of the adrenal gland is not done routinely unless the adrenal looks abnormal at the time of the surgery or there is a direct extension of the tumor into the adrenal.
Okay, this patient has uneven full robot assisted left radical nephrectomy. The histology shows 11.5 centimeter poorly differentiated renal cell carcinoma. No evidence of any surgical positive margins, adrenal not included in the specimen. Is there any way we can grade the patient's histology of RCC?
Yes, we have previously the formal grade for grading of the cancer. Now we have the International Society of Uropathologists grading, which composed of 4 grades. So grade 1, usually the nuclei are not visible on magnification of 400. Grade 2, the nuclei are visible on a magnification of 400 and eosinophilic. Grade 3, they are visible on the eosinophilic on a magnification of 100. And the grade 4, there is a widespread nuclear pleomorphism and involvement by sarcomatoid or rhabdoid element.
Okay, very good. Again, clean performance, no concerns. Only thing is, when I am discussing about how will you decide between whether to just take the CT urogram as good enough to decide about radical nephrectomy, or you want a specialized renal tumor protocol CT scan. You mentioned about radiologist, but you haven't brought in MDT. But overall, nobody will remember whatever you have missed if it is a very small things like that. If you are able to go through the same scenario again in our YouTube recording, you can see that in the second scenario, you haven't really bought the MDT at any point, but it doesn't matter at all. Okay?
Okay.
Good. We have time for one more. Are you happy with that?
Yes, please.
Good. Your time starts now. You are a urology surgeon specialized in upper tract oncology. One of your colleague has referred you a patient. Patient is fully worked up. Patient is a fit 59-year-old gentleman. No past history of any significant medical or surgical illness. He presented with lower limb edema to the medical team, and on evaluation they found right-sided renal cancer, replacing the whole kidney involving the adrenal, and also the tumor seems to be extending the renal vein and IVC. Since you are an upper tract renal specialist, the patient is referred to you. How are you going to take it further?
So I will see this patient in my oncology clinic. I will be accompanied by the cancer nurse specialist. I'll explain to the patient the finding of his CT. I will take from the patient a history, asking about any symptoms like loin pain or hematuria, any systemic symptom, weight loss, nausea, vomiting. I will ask about his past medical history, any other comorbidities, medication, including anticoagulant, antihypertensive. I will ask also about his past surgical history, any surgery, radiotherapy, any smoking, and his social life. And then I will ask about family history, if there is any family history of renal cancer.
Sorry to interrupt. Let us assume that he is completely worked out. There is no significant findings. And patient had a CT renal tumor protocol, including the chest, the findings I told you. So how are you going to take it further?
So I will discuss this case in our MDT, and this patient, according to the CT scan, is stage 4, since the adrenal is involved and there is involvement of the renal vein and IVC. There is no metastatic deposit. Apart from that, the most likely decision from the MDT is to consider a radical nephrectomy with excision of the tumor thrombus from the IVC. So I explain to the patient the recommendation from the MDT, and I will consent him for the procedure.
Okay. What preparation you will do with specific to this patient's nephrectomy and IVC involvement?
Since this is a big tumor with wide local extension, it may be challenging to be done via robot or laparoscopy, and I would prefer this to be done via open surgery with the help of a senior colleague and possible involvement of vascular surgeon as well.
Okay. What kind of incision is your choice, and take me through the major steps in the procedure?
So the incision will be a thoracoabdominal incision or bilateral chevron incision. Usually the procedure will start first by removal of the a tumor thrombus. I need to localize the level of the tumor of thrombus because we have four types of IVC tumor thrombus. So if the information are available from the CT, it's fine. If not, then I will arrange for MRI for better evaluation. And after that, I will assume if the tumor is if the thrombus in the IVC is subdiaphragmatic, then we will apply a clamp above and below the thrombus. I will apply a vessel loop over the renal veins on both sides. And then after that, I will open the IVC, extract the thrombus, and then suture the IVC with proline. And after that, I will proceed to doing the open radical nephrectomy.
So if the tumor has extended up to aorta, atrium, what is your choice?
So for this patient, I need to evaluate him by echocardiogram, and I will involve our cardiologist's opinion before we start. And then I will need possibly a cardiac surgeon to be available at the same time. For this patient, we need a major surgery with cardiopulmonary bypass and hypothermic circulatory arrest to be done, and then we will open the IVC above the diaphragm and try to remove all the thrombus, including the one in the atrium.
Any other intraoperative equipments you need in this patient's preparation for surgery?
I think it is mainly the cardiopulmonary bypass, hypothermic.
Okay.
No, I'm not aware of anything.
Okay. If the patient's tumor seems to be inoperable, let the tumor thrombus extending in the IVC up to the intrahepatic segment of IVC, but overall tumor seems to be inoperable, adrenal not able to differentiate, the tumor seems to be involving the posterior paraspinal muscles and the hilum also not clearly delineated. Anything you can do before ending up into a very challenging radical nephrectomy?
Yeah, one of the things is possible consideration of embolization preoperatively, and this may help to shrink the size of the tumor a little bit and reduce vascularity, which may help. That's what I'm thinking about.
Any other drugs possible in this situation pre-op?
Yeah. Yeah, there is a possibility of neoadjuvant treatment with TKI, like sunitinib, and also recently treatment with immune checkpoint inhibitors may be helpful prior to the radical nephrectomy.
Okay, you are happy to continue another 2 minutes, okay?
Yes, please, yeah.
Good. And how these drugs help in achieving a good radical nephrectomy?
The idea is that why we give immunotherapy and TKI before radical nephrectomy for metastatic disease is because the tumor will induce some immunosuppression, and this medication may help to improve the immune status of the patient before the surgery.
Okay, let us assume that this patient had a bit of a challenging but uneventful right radical nephrectomy, and the tumor thrombus and involvement of IVC is cleared, and she had some ITU support for a day or two and then recovered. What is your follow-up? Her histology showed 13 centimeter, poorly differentiated, right-sided, clear cell renal cell carcinoma, and most of the extension into IVC is just a tumor thrombus.
Yeah, so I will risk stratify the patient according to the Levo-Bitch score, which depend on the T stage, on the presence of lymph node or not, the tumor size more than 10 centimeter, the presence of necrosis in the histology. So I will, according to the Levo-Bitch score, this patient looks to be on the high risk side. So for this patient, I will arrange for follow her with a CT scan, chest, abdomen, and pelvis every 3 months for the first year, and then it will become every 6 months for 4 years, and then after 5 years, it depends on a discussion about the risk, about the fitness of the patient, and then we can plan it further.
Okay, her first 3-month CT scan is clear, but unfortunately the 6th month CT scan showed multiple cannonball metastasis in both the lungs. What is your next approach?
So this patient unlikely to be helped by any surgery since the metastases are multiple. So the only option is to give her a systemic treatment in the form of a tyrosine kinase inhibitor or immune checkpoint inhibitors.
So what is your cutoff for surgical intervention for metastasis in RCC?
Usually, if it is a solitary metastasis in soft tissue or glandular tissue, then the survival are good after removal of the metastasis. But when it is multiple, it's unlikely that it will give a survival benefit for the patient.
Could you take me through some immune checkpoint inhibitors for RCC?
The immune checkpoint inhibitor are mainly the PD-1 and PD-L1 inhibitors. The idea is that the PD-1 and the interaction between PD-1 on the T cell and the PD-L1 receptor on the tumor cell would lead to immune suppression and inactivation of the T cell. So when we give PD-1 or PD-L1 inhibitors like atezolizumab, nivolumab, pembrolizumab, this will reactivate the T cell mediated tumor killing, and this will improve the response.
Good. I'm quite happy to stop. Again, good performance. Just to feedback on few things, you can bring in the enhanced recovery protocol. The nurses can see the patient even in the pre-op, especially the third scenario. Of course, even for second scenario also. And that will help you in the post-op also, including ITU. Whenever the scenario is given like fully worked up, there is no point in going back to history, family history, smoking history, etc. I understand that's how we practice, but you can boldly say, I hope that the patient is fully worked up, as you said. I will go through my images with MTT and then just go bang on. That is the only way you can reach the end of the scenario, like this TK inhibitors and tyrosine kinase inhibitors and the immune checkpoint inhibitors. I have touched only the immune checkpoint inhibitors. If there is another 1 minute, possibly I may have asked you about the tyrosine kinase inhibitors, which helped you to bring in sunitinib, sorafenib, and maybe some studies like Sutent study, Carmina study, something which you can bring in that really increases the weightage in the answer. But answer wise, everything is complete. I have no major questions. Other than that, you may have to bring in something like IVC. When it is opened, you may need to use something like a patch to repair the IVC that can be stressed out. And if the tumor is extending above the diaphragm or into the atrium, you need sometimes a cell saver, because patient may lose some blood, and then you may have some RBC cell savers so that you can do some auto transfusion. Those things can be discussed. Yeah. I think we have discussed quite extensively. I'm happy with whatever you said. I'm just helping you to get the best out of you. And in the histology, again, you can say that I will ask my pathologist to do a PD-L1 staining. That will help you to decide which immune checkpoint inhibitor is quite ideal, or whether the patient will respond to that or not.
Yeah. Thank you very much.
Good. I know you're a bit time constrained. Any questions from your end?
No, I was just have a concern about oncocytoma, because like in my hospital, for example, they rely on the biopsy to say that this is oncocytoma. So how much is the biopsy is reliable to say confidently that this is oncocytoma, and are we going to discharge the patient after that, or we are going to follow him?
Yeah. Regarding oncocytoma, our main worry is oncocytoma can mimic like a chromophobe malignancies or vice versa. We can take the size criteria 4 centimeters. If it is less than 4 centimeters, if there is no signs of any chromophobe RCC or any RCC, we can follow them maybe for 3 years, and then if the lesion is absolutely unchanged, we can discharge them. More than 4 centimeters, anyway, even if it is a biopsy proven oncocytoma, chances of bleeding is quite high. So patient will need much more longer follow-up. Patient, if it is pregnancy, we may have to do something even like a pre-pregnancy embolization, etc., or partial nephrectomy to make sure patient doesn't have a bleeding episode during the pregnancy, which is more common in AML compared to oncocytoma. So in brief, if the biopsy source oncocytoma less than 4 centimeter, stable lesion for 3 years, you can discharge back to GP. Ask the GP to do annual renal ultrasound. More than 4 centimeter, if the patient is symptomatic or if there is any bleeding episode, you can offer surgery even for oncocytoma or needs longer follow-up.
Okay, thank you very much.
Always when you discharge these patients, make sure that you ask the GP to do an annual ultrasound. It is not fair for the patient to have a CT scan in the community, but ultrasound annually is quite safe to monitor the size and diagnose the things at an early stage.
Okay, thank you very much.
Good. Again, wonderful performance. I will try to squeeze in at least 1, if not 2 sessions before your exams. Well done.
Thank you. Thank you very much.
Good.
Have a nice day.
Thank you. Have a good evening. Bye.
Thank you. Bye.